We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Jesse, my friend, how are you doing?
I'm doing pretty well. How about you?
I'm good. You know, I'm on maternity leave right now, so I'll be going back to work soon. And, you know, that reminded me, do you know why babies born on holidays are more than likely to be little girls?
Because little girls like holidays more than little boys?
Well, no, it's because there's no male delivery on holidays. Oh, yeah, I gotta weave that in here. All right, let's jump to it, okay? You ready?
Yeah.
All right. Well, we have with us today Dr. Stella Hines. She's going to talk to us about tolerability, user acceptance, and preference for a novel reusable respirator among healthcare workers. It's a really neat article. Dr. Hines, MD, MSPH, is an occupational medicine physician and pulmonologist, currently serving as the Field Studies Branch Chief in the Respiratory Health Division of the National Institute for Occupational Safety and Health, also known as NIOSH. She previously was an associate professor at the Yale School of Medicine. She received her BA from Rice University and MD from the Texas A&M College of Medicine. She completed internal medicine residency at the University of Chicago Hospitals and Pulmonary and Critical Care Fellowship, Occupational and Environmental Medicine residency, and Master of Science in Public Health at the University of Colorado, Denver, and National Jewish Health. Dr. Hines studies reusable respirator use in healthcare to address N95 shortages and has published and presented on this topic at national and international meetings. She also provides clinical care and conducts research related to exposure-related lung disease. She's the immediate past chair of the American Thoracic Society's section on terrorism and inhalational disasters. So that is really cool. Welcome, Dr. Hines. We're so happy to have you. Yeah.
Thank you.
Why don't you kick us
here.
off and just tell us what prompted the study?
Sure. So prior work in elastomeric respirator research before COVID saw that healthcare workers actually preferred elastomerics over N95 respirators despite lower comfort and communication scores in high-risk scenarios. And the Clean Space Halo was this new reusable respirator that had come out that actually did have higher protection, but some engineering designs that theoretically should also improve tolerability of this respirator. So we wanted to understand if the user perceptions for this respirator would be similar to what we had seen previously with elastomeric respirators. And you know, studies have shown, and I don't think this is a surprise, that user comfort is a predictor for compliance with expected respirator use. So assessing comfort and tolerability is really important in increasing kind of compliance with respiratory protection programs, but in also keeping healthcare workers protected, happy, and able to do their work. So that's why we wanted to look at it in this particular respirator.
That makes a lot of sense. It seems very sort of common sense to think of it in that from that perspective. Dr. Hines, can you describe the different types of the reusable respiratory protective devices available for healthcare workers and how they might differ?
Sure. So to kind of give a frame of reference, I think almost everybody in healthcare now knows about kind of the traditional N95 respirator. So this is a disposable mask that's meant to be used once and then discarded. And in an N95 filtering face piece respirator, most of the mask itself is made of filter. And I think it's important to kind of remember to call these filtering face piece respirators N95 FFRs, because there are also N95 filters that are just filters, and they can fit onto other types of face masks that are reusable, such as elastomerics. So then we get into the reusable sphere. So first, elastomerics. Elastomeric respirators are reusable face masks that usually are made of like plastic or kind of a vinyl or silicone type kind of elastomeric mask that are equipped with with attachable filters. And those can be N95 filters, but they can be other kind of higher efficiency filters like a P100 filter. And these respirators are intended to be reused and come with instructions on how to clean, disinfect, and reuse the respirator. And elastomerics can either cover just the nose and the mouth, and that's called a half mask, or they can encircle the whole face like a snorkel mask, and that's called a full face piece respirator. So elastomerics are routinely used outside of healthcare in general industry, and all they did have some limited use in healthcare prior to COVID-19. Hospitals and healthcare workers certainly, I think, incorporated them due to the shortages in N95s and PAPRs, especially at the beginning of the pandemic. So then we come to the next category of reusable respirators called PAPRs, and that stands for Powered Air Purifying Respirators. So these are respirators that have a motor that pulls kind of the outside contaminated air through a filter and then supply it to the user's breathing zone. And the air that is supplied, usually at a constant flow rate and at an amount that keeps the air inside the respirator under positive pressure compared to the air outside of the respirator. And so because of this positive pressure, loose-fitting hoods or caps that don't rely on having a seal to the face can be used, because the clean air will always be displacing any contaminated air outside of the respirator. PAPRs usually are equipped with higher efficiency filters, like a HEPA filter, and PAPR power units and hoses are intended to be reused, so they can be cleaned and disinfected. But the head coverings, like with a loose-fitting PAPR, that I think that's probably what most healthcare environments have used with PAPRs, historically, those have been considered to be disposable. But during COVID, again, we started to see cleaning, disinfection, and reuse of those loose-fitting PAPR hoods. And so one of the differences, again, with the elastomerics, as well as N95s, is that because those are negative pressure masks, meaning that they rely on a tight seal between the face mask and your face for that ability to filter out the air and provide that protection to be in place. Whereas with a PAPR, it's positive pressure. And so the negative pressure respirators have to be fit tested. Someone has to be medically cleared for respirator use. But the fit test is not required for a PAPR. I get asked sometimes about, what about a CAPR? So that stands for Controlled Air Purifying Respirator. So that is just a proprietary version of a PAPR. It still has a battery pack on the belt and a power cord. But in that case, the helmet is meant to be reused. It's meant to be disinfected. But it does have some disposable components that are meant to be kind of single use. So the respirator that we studied in this article is called the Clean Space Halo. So it is a reusable respirator, but it's kind of like a hybrid between a PAPR and an elastomeric respirator face mask. So what does this look like? So it has a clear face mask that covers the nose and the mouth. And that face mask connects to this power unit / blower unit that actually goes right behind the neck. And it has a head harness that helps to support and hold it in place. So there's no belt, there's no hose, there's nothing that is on the body lower than the neck. And the whole apparatus weighs less than a pound. And so the way it works is that it pulls in air from the outside space into the air intake behind the neck where the filter is located, and it is a HEPA filter. And then kind of the battery kind of powers that air through the side piece that goes around the neck into the face mask, that clear face mask that kind of looks like a CPAP face mask. And so the user is getting that kind of really cleaned air. And what's really kind of cool about this respirator is that it's breath responsive. So if you as the wearer are doing more work and you're breathing more, that battery is going to activate and it's going to blow more air into your breathing zone, as opposed to just kind of relying on a constant flow rate. And the respirator, while it does have kind of that elastomeric looking face mask that, normally in a negative pressure kind of normal elastomeric mode, you really are reliant on that seal to the face. Here, if in the course of normal, activities, which happens in healthcare, you get a leak between the face mask and your face, the blower unit's just going to blow more air into it. So you're always under positive pressure, even if you have a break in the seal. So that is kind of one of the unique things about this respirator, and part of the new kind of set of devices we have that are meant to be reused.
Wow, that is very cool. Just a comment on something that you mentioned as you were talking through the different types is that I think that's important for people to understand the differences and what the sort of acronyms stand for, because I can't tell you how many times we would have to say an N95 is a respirator, because people thought that the elastomeric respirators that were put into use were somehow safer or different in some way. So I think it's important for people to understand, which respirator they're using, how it functions, and, what the level of efficiency is for them. And then thinking, I have one question about the halo, since you were describing how it looks, is because that face mask is clear, does that make it more... does it give the person wearing it a better ability to, let me rephrase this because this is not coming out right. So because that face mask is clear, does it actually help with patients who may be hard of hearing so they can actually see the person's mouth?
That's a good question. Yeah.
So theoretically, that's possible. I don't think anyone has studied it yet. But when the unit is on under positive pressure, you absolutely can see all the facial movements, which is kind of one of the key design aspects that is unique about this respirator.
So, yeah, and go ahead, Nikki.
Well, no, I had a question in addition to that, because during COVID, and I'm sure we all had the same experience as infection preventionists and working in this field, trying to educate some of our friends and population and community about wearing. A lot of people didn't want to wear masks, and so face shields were another option for the general public to wear. And I was wondering if this would help a lot if this could be... I'm having troubles rephrasing this too. Is it possible that this mask could be used in the general public in the future if we had another sort of pandemic where we had to do this? Because I think that would increase compliance for people who are in industries like real estate where a lot of it depends on communication. And so being able to read lips and have that full face visibility. Is it possible that this mask could be transferred into the public use?
Yeah, I mean, I think theoretically, yes. It's got a cost to it that, it costs a lot more than an N95 or an elastomeric. So that would be an issue. But from a practicality standpoint, it absolutely does allow kind of facial expression. It does have, like all PAPRs, it does have a sound component to it. And so, I don't know that we've got the ideal respirator from a kind of, minimizing noise, optimizing communication, but it absolutely allows that kind of transmission of facial expression.
Yeah, I think this is we're already like going off on tangents and talking about these things because it's so interesting. But to get back to something that was mentioned in the article, they were talking about the assigned protection factor, or APF. And this is not something that I was familiar with. So can you talk a little bit about what that is and who decides what an APF is for a particular mask?
So APF is actually really important. So APF, which stands for Assigned Protection Factor, defines the minimum level of protection that can be expected from a respirator of a certain class, certain type or class, when it is functioning and worn properly by a trained and fit-tested user within the context of an effective respiratory protection program. So it's not just for like anybody that picks up a respirator and puts it on their face. It's like within all those caveats, like they've been trained, they know how to use it, they've been fit tested, someone's paying attention to the respiratory protection program. But the APF is determined by OSHA based on a review of something called workplace protection factor studies. And in these types of studies, they'll have people doing actual work tasks, but they'll have some sensors inside and outside of the respirator itself, where it can determine the concentration of contaminants measured inside and outside of the respirator. And so then the outside concentration is divided by the inside concentration, and that is called the protection factor. So if you think of that differently, this represents the APF represents the fraction of the outdoor concentration that the user might still face exposure to. So a higher APF represents more protection. So for example, a respirator with an APF of 10 should reduce the concentration inside the mask to at least 1/10 of what the concentration outside the mask is. And a respirator with an APF of 50 should reduce that in-mask concentration to 1/50th of what the outside concentration is. And so, while we spend a lot of time at least talking about the filter efficiencies, like 95 on an N95, that's a 95% filtration efficiency. So the protection factor is supposed to account for the total amount of leakage inside the respirator when it's used properly in an actual work setting. So that accounts for opportunities like seal leaks. But there are some challenges with APF because these values are assigned, typically for an entire class of respirators and not necessarily measured for every type and every class of respirators. So for the half-face respirators like an N95 or a half-face and elastomeric respirator, the OSHA assigned protection factor is 10, even if that elastomeric respirator is equipped with higher level filters like P100s. So again, that is a source of controversy, for example, as some literature suggests that the total leakage from half-mask elastomeric respirators is actually better than N95 FFRs, but they still have the same APF. So that is kind of an ongoing level of, there's communication about that in the respiratory protection world. But for these other respirators that we've talked about already, so for a loose-fitting PAPR, the assigned protection factor is 25. And then for the Clean Space Halo, where it's got its half face, but also under positive pressure, its assigned protection factor is 50. And this is similar in magnitude to a full face piece elastomeric respirator that would go around the whole face, or to certain types of self-contained breathing apparatus.
Nikki, can you just imagine us having arguments about ABFs? Because I can't.
I was just thinking like this opens up a whole new set of terminology and education to dole out, but it's really neat. I mean, and it could be it could open the door to arguments, or it could open the door to people feeling a lot more comfortable. Okay, this is the level of protection that I get from this, or some comfort that they're getting that protection. I don't know. Yeah, that's a whole new conversation. Dr. Hines, I know for this study, the focus was on halo respirators. So why was that specific respirator selected?
So I had, as someone who had been doing respirator research, I had learned about this respirator in 2018 at a meeting of the International Society for Respiratory Protection. This is a group open to membership. Look it up. But at this meeting, the kind of manufacturer was there presenting, and they had this really novel design that offered high protection, and it really addressed some of the key design needs that had previously been identified by something called Project Breathe, such as this clear face mask. But because some of the issues that would be related to use would be similar to what we had previously studied with reusable elastomeric options, this really presented an opportunity to see if we saw the same issues related to the logistics of use and the same perceptions even in this respirator with this novel design. So the study was an investigator-initiated but industry-funded study. So what that means was, I and my colleagues at University of Maryland, we developed a study protocol. We proposed it to the company, and they decided to fund it. So this was finalized in 2019, prior to us even thinking about COVID. And originally, there was a different study design where we were going to randomize different healthcare workers to use this respirator under different deployment strategies, such as individual-based maintenance versus centralized, and then COVID hit. And because of just like how the hospitals really wanted to deploy and how they were able to deploy these respirators, we had to change some of our original plans, and then we ended up studying some of these user perceptions more in depth, specifically focusing on this respirator. But I think kind of it does add new information to that whole idea about user perception with a device that nobody else had really used before.
Yeah, and I think we all know that, regardless of the level of protection offered, that in order to maintain good compliance with wearing any kind of PPE, that the PPE needs to be relatively comfortable. So can you talk a little bit about the survey instrument called the Respirator Comfort Wearing Experience and Function Instrument, which I think is just called R-Comfy, and how it was used to evaluate that respirator, the Halo respirator? Sure. Thanks.
So the R-Comfy was designed originally by investigators in the VA, in the Veterans Administration, as a tool to study user perceptions, originally about N95 filtering face piece respirators. It emerged from this thing that I referred to before called Project Breathe, which stood for Better Respiratory Equipment Using Advanced Technologies for Healthcare Employees in 2013. So Project Breathe was this group of federal stakeholders that came together to craft a priority list for characteristics that healthcare respirators should have, ranging from characteristics that improve tolerability to other domains like durability and effectiveness. And that list was actually published in the American Journal of Infection Control in 2013 by GOSH. And ultimately, those investigators studied the psychometric properties of this tool, and it had good, reliability and validity. And then they trialed it among a group of healthcare workers doing simulated healthcare workplace tasks wearing either N95 or prototype respirators. And it showed that those prototype respirators that had been developed based on some of those concepts that Project Breathe came up with, it showed that using that tool, those prototypes had better tolerability scores. And this is the only validated, standardized survey instrument still today for assessing respirator tolerability. So we wanted to use something that had been validated and something that future studies could be compared against. And, I think one of the things that I really think is important about this tool is because it assesses this concept of tolerability. So when we talk about respirator comfort, which gets included in the literature a lot and just in our conversations, that means different things to different people. For some, if they say it's uncomfortable, maybe they mean it's hot. But for others, maybe it means it actually hurts. Maybe it means it causes pain to their face. So if a respirator manufacturer is going to make a more tolerable respirator, they likely are going to need to develop different design elements that will address specific components. So something they do to address heat may not improve how it feels with respect to irritation or kind of a perception of pain on the face. And to a wearer, we just want the whole experience to be good. We want the entire domain of tolerability. And so we want it not to be hot. We don't want it to pinch our noses. We want to be able to communicate effectively. We want facial expression. And so this Our Comfy tool allows us to address that through a total score, but through the different domains. And I really think it's the future for respiratory protection user experience research.
Yeah, I think all of those things make a lot of sense and are extremely important to the users. And I think both Nikki and I observed some of the issues during the pandemic, when we were observing employees having to wear the different types of respirators. And there were there weren't a lot of options available. You had a couple of different things available at your hospital, and that's what you used. But so for this particular study, how many staff were recruited and how were you able to recruit them?
Yeah. So we think we had about 389 healthcare workers who were eligible to participate. So these were people who had undergone fit testing and training to use the Halo respirator. And really, we didn't have any other exclusions than that. They just needed to be 18 and have been trained and fit tested. Okay. So we recruited several ways. We sent email invitations to complete this electronic survey to the kind of roster lists of people who had been fit tested. We handed out flyers with QR codes to go to the survey at different units during site visits. And we actually came to some of the high volume units like the emergency departments, the ICUs, break rooms for the respiratory therapy staff, so that people could complete this survey on the spot. We really wanted to make it easy and so that it didn't interfere with anybody being able to do their jobs.
That's awesome, because convenience is definitely key. Do you think that based on the number of recruited respondents to the survey that you had sufficient responses and enough to come to some conclusions about the tolerability and comfort comfortability of the Halo respirators versus other types of respirators?
Yeah, so we had a 30% response rate based on the rosters of participants who were eligible. And while I think anyone doing survey-based research wants as many responses as possible, this 30% response rate is fairly similar to what we've seen in prior electronic survey studies about respiratory protection. So I guess we're not too surprised. But we had originally designed our sample size kind of based on significant preference differences in a prior study, and we did exceed that sample size. And so I think we can draw conclusions based on how these healthcare workers were using Halo during, at least in the setting of COVID-19 care.
Great, thank you.
Yeah, and I found it interesting, too, that this study seemed to support findings by others that performed similar studies. So could you highlight some of those findings?
Yeah, so I think kind of one of the first things we wanted to know is, all right, we have these R-Comfy scores for these Clean Space Halo users. How does that compare to anybody else? And so the only time R-Comfy has been used previously was in this group of healthcare worker doing simulated work tasks, wearing prototype respirators and N95s. And so the different domains of this tool are discomfort, general wearing experience, and function. And so we saw similar scores to the N95 users in terms of that discomfort, but we saw actually a lot better scores compared to that study in the general wearing experience. And the questions related to general wearing experience ask about, dizziness, fatigue, claustrophobia, shortness of breath, or kind of dry or itchy eyes. So like notably better scores using the Halo. And then we saw a little bit higher, or in the terms of the R-Comfy directionality, a little bit worse scores with respect to function. And that asks about kind of verbally communicating and hearing and things like that. But in just kind of the world of that Clean Space Halo respirator, there's a couple studies that have been published. I think one that's probably most similar was a study conducted at the end of 2020, so during COVID, in Singapore. And in that study, out of a population of 92 healthcare workers, 40% thought that respirator was comfortable to wear for greater than 4 hours. And while we didn't ask a exactly comparable question in our study, we saw in our study that the population, like 50% of these users said they were using it or the majority of users in our study said they were using it for greater than half of their work shifts. So that's a lot of use. So I think we've got some kind of, comparison in that population. But the last thing I'll say on that is kind of compared to elastomeric users. So we had previously published in American Journal of Infection Control on that pre-COVID. We saw higher scores in the current study with the Clean Space Halo users with respect to questions about how much do you like your respirator with regard to comfort, communication, perceived protection, and confidence that the respirator would protect them. So across the board, we saw better scores among the Halo users during COVID when they're using it a lot compared to what we had seen in the prior elastomeric respirator study that was published in 2019. So I think that these findings are really kind of reassuring given this really heavy respirator use time period when healthcare workers were really familiar with respirator use at this time.
Yeah, and what do you think might have shaped survey participant perception of risk level for the Halo respirator versus the other types?
So I hope it was shaped by training and education. So, because it is a more protective respirator. So just based on that assigned protection factor being so much higher. But each hospital that was participating in this study received training to a group of super users and fit testers by the manufacturer, by the clean space company. That was their model of rollout during COVID. And during those initial kind of super user training sessions, the company taught participants about that higher level of protection. And I think that was also taught to the healthcare worker users during their own fit testing and training by the super users and the fit testers. And so I think that it likely stuck. And we did, as part of this effort, we collected some post-training knowledge checks. And I think that may be something that we can report on in the future.
Well, it's always interesting, personally for me, to see the results of the survey that includes a variety of demographics and occupational characteristics. So I was not surprised when the majority of the respondents were white, women, and nurses, or that the majority of the respondents had used an N95, because most healthcare workers have had some level of exposure to N95s. So based on the demographics and characteristics of the respondents, were you surprised or not surprised about any of the tolerability or preference scores?
So I was kind of surprised to see that one of the things we found was that workers with fewer years of work in healthcare tended to give better scores to the halos. And so I kind of thought going into this that the more, experienced, seasoned workers would perhaps really respond to some of the technological differences in this respirator in comparison to years of wearing N95s, especially given all of the different practices that had gone into place regarding N95s during the first year of COVID, like reuse and decon and storage and all of that. So it may be that the technological improvements in this respirator, maybe they feel pretty cool to these new users that haven't used a respirator before, and maybe they were more willing to kind of accept it. And so I think that was one of the things that I really didn't anticipate going in. But I think that's got some significant implications kind of going forward.
Yeah, definitely. Do you think the location in which the staff worked biased their responses in any way? Like, for example, those staff that were respondents to the survey that had cared for a large number of COVID patients?
Yeah, I think that's always possible, but we really tried to account for that. So all of the scores were not statistically significant. The R comfy scores were a little bit different. They actually were lowest among the workers working in the emergency department, and a lower score is a better score. And they were a little bit higher in the dedicated COVID units. And so I don't think the fact that we did have a lot of healthcare workers who exclusively worked in COVID units biased the results more significantly in a more favorable way for the R comfy scores. And I don't know if it's just kind of, in the emergency department, you never know what you're going to get. And so there may be something about that type of an environment that kind of, predicted their more favorable ratings of this respirator.
Yeah, potentially. It is interesting, though. It's an interesting thought.
So tell us some of the limitations of the study.
So I think sample size, as we kind of discussed earlier, we had the 113 participants, and that was about 30% of the eligible respondents. And, in this study, we asked a baseline survey, and then we asked a follow-up at 4 and 8 weeks. And we had 50% attrition for the subsequent surveys. So, it made us ask, what can we really rely on these kind of change over time endpoints. But the demographics of the subsequent survey group were similar to the entire pool of initial survey completers. So I think hopefully we did not get a biased pool of the subsequent survey respondents because they were fairly similar. We didn't have like all the nurses drop out and only respiratory therapists remained. So I think that was helpful. Also, we did not see any change in the opinions at that 8-week interval mark. And, we originally had planned to survey these users right at initial Halo use, like something they had never used before. And we had hypothesized that their opinions would change over time with increasing use. But due to some of the COVID limitations, the first surveys to these surveys that we used to these healthcare workers occurred around 6 months after first being trained. So we were limited in being able to assess for change in user acceptance really right after initial use due to the timing of when we were able to start. And I really wish we'd been able to comment on that from our evidence.
How about some key takeaways for our listeners?
So I think, we have shown that Halo is an acceptable and even preferred form of respiratory protection with the highest assigned protection factor of any style of respirator used in healthcare. So compared to other PAPRs where the hoods are disposed of at interval thresholds, these Halo face masks are intended for repeated cleaning, disinfection, and reuse. And so I think for hospitals that are planning investments, particularly in PAPRs, Halo likely comes at a lower cost over time with an actual evidence base to support preference. I think the second thing is that given the changeover in the healthcare workforce during and as a, subsequent to the COVID pandemic, the demand for new graduates of health professions training is really high. And so given that this shorter time in healthcare predicted these better R-Comfy scores in our study, this population of new healthcare workers maybe represents a target population group that's likely to embrace use of this kind of novel respirator. I think future research studies that are assessing healthcare worker opinions about respirator tolerability really have an opportunity to use this R-Comfy to allow for comparability. And then finally, that studies, not just from healthcare, but from many other industries, have repeatedly shown that comfort or tolerability of a respiratory protective device is a determinant of whether people will wear it or not, which in the global sense makes comfort a fundamental safety issue. So comfort is not a luxury. Comfort is vital for our safety as healthcare workers. And so, I think we as healthcare workers will do our part in setting up respiratory protection programs and wearing the respirators when we need to. But improvements in comfort and tolerability, that's what we really need from respirator manufacturers.
Yeah, that's awesome.
Yeah, and I think there's a whole new crew of nurses. They're not new anymore. COVID's been a few years, but there's a whole group of healthcare workers that came in during COVID and had to kind of trial by fire use these PAPRs, N95s, all the respirators. And I think this is going to be a really cool innovation for a lot of those people too. But anyway.
Yeah. Thank you so much. Both Nikki and I found this article very interesting, and we always love hearing about the newest technologies available and being able to share that with our listeners.
Thank you very much, and I'm really happy that this was published in American Journal of Infection Control. This is the audience that really is confronting these kind of issues every day.
Absolutely. Well, thank you, Dr. Hines. That was a fun episode, so thank you.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alton. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.